Welcome back to another video. We'll be seeing on retention and relapse. Moyer defined retention as maintaining newly moved teeth in position long enough to aid in stabilizing their correction. Relapse was defined as the loss of any correction achieved by orthodontic treatment. The causes of relapse include periodontal ligament traction. During orthodontic treatment, it causes stretching of the periodontal ligament and the gingival fibers. The fibers contract and cause the relapse. The principal fibers of the periodontal ligament rearrange themselves quite rapidly to a new position within about 4 weeks' time. The supraalveolar gingival fibers take around 40 weeks to rearrange around the new position. Thus, they predispose the relapse provided proper retention period is not continued. The second cause of relapse can be due to growth-related changes. Patients with skeletal class 2, class 3, open bite or deep bite may exhibit relapse due to the continuation of the abnormal growth pattern after orthodontic treatment. Prolonged retention is indicated until the growth period is completed. Third cause of relapse include bone adaptation. Newly moved teeth are surrounded by lightly calcified osteoid bone. Thus, the teeth are not adequately stabilized and have a tendency to move to their original position. Fourth cause includes the muscular forces. Muscular imbalance at the end of the orthodontic treatment can result in the reappearance of the malocclusion or the relapse. Fifth cause includes the failure to elucidate the original cause or the actual cause. Failure to remove the etiology of the malocclusion can result in relapse. Third molars play a role in relapse. Most patients would have completed their orthodontic treatment before the eruption of third molars or during the eruption of third molars, around 18 to 21 years of age. The pressure exerted by the erupting third molars is believed to cause late anterior crowding, predisposing relapse. Role of occlusion in relapse. The centric relation and the centric occlusion should coincide or slide from centric should not be 1.5 to 2 mm in order to have a greater stability of the orthodontic treatment results. The 10 theories of retention. It can be easily remembered with a small mnemonic. Tempo with air, conditioner, but you have to go far, so you decide to alter it with train. So first theorem says that teeth that have been moved tend to return to its former position. The cause of this relapse are many and the single etiology cannot be highlighted. Theorem 2 states that elimination of the cause of malocclusion will prevent relapse. Failure to remove the cause increases relapse potential. Theorem 3 states that malocclusion should be overcorrected as a safety factor. Theorem 4 states that proper occlusion is a potent factor in holding teeth in their corrected positions. Obtaining correct intercuspation and proper functional occlusion are essential factors in occlusal stabilization. Theorem 5 states that bone and adjacent tissues must be allowed timely to reorganize around the newly positioned teeth. Theorem 6 says if the lower incisors are placed upright over the basal bone, they are more likely to remain in good alignment. Theorem 7 says corrections carried out during periods of growth are less likely to relapse. Theorem 8 states the farther the teeth have been moved, the lesser is the risk of relapse. Theorem 9 says arch form, particularly in the mandibular arch, cannot be permanently altered by appliance therapy. Alteration of existing arch form results in increased risk of relapse. Theorem 10 was added by Moyer. Many treated malocclusions require permanent retaining devices. Thank you.